Good afternoon, everyone, and thank you for joining our webinar on technologies leveraged in COVID-19 response and recovery. My name is Guillaume Zwirek, and I am the founder and CEO of Well Health. If we can jump to the next slide, Sarah. I am thrilled to be hosting Dr. John Kontor today. John leads the Provider Technology Services practice within Optum Advisory Services. His team advises clients on EHR implementation and optimization, pop health and value-based care operations, clinical IT workflows, as well as IT strategy. And before his illustrious consulting career, John actually practiced internal medicine for 14 years, and he focused on ambulatory chronic disease management and inpatient critical care. I was originally meant to host John for a session at HIMSS, and we were actually in a planning meeting when we got the notification that the conference had been canceled. I don't know that many of us could have anticipated how much things would change since that time. So I'm really pleased today to welcome John. You'll be hearing from him about the trends that he and Optum Advisory Services are seeing, as well as some of the best practices they're advising their clients on. I will then host a Q&A where we'll accept audience questions. Please use the questions section in the dashboard on the right-hand side. You'll see an option for questions. To ask any questions, you're welcome to do that during the presentation. We will be fielding those, and we will raise those directly to John when we get into the Q&A portion. So with that said, John, thank you so much for joining us. The floor is yours.
Guy, thank you, and thank you everybody who has joined the webinar. We'll try to make this not too much talking, but leave plenty of time for questions at the end here. And if we could go ahead and advance the slide deck. So this is obviously the key question that everyone across healthcare and everyone across the planet is focused on, which is what are we facing in both the near term and in the long term future, and specific to this conversation, how does that affect key stakeholders across the healthcare continuum, payers, providers, technology companies, and first and foremost, our patients, consumers. Sarah, if we could advance. So I think, as you all have experienced, the one thing we're most certain about with COVID is uncertainty. The disease itself has been highly unpredictable. The human, social, governmental response to the disease has been highly unpredictable, and that uncertainty is continuing, I think, somewhat certainly longer than most of the industry predicted initially, and I think we can be confident in an uncertain future as well. And again, I think that comes from a couple different angles. We're still not sure how the disease is going to act, obviously interacting with all those other factors. In many parts of the world, and certainly in the US, we are in the midst of a significant second wave, or maybe it's just a second crest of the first wave. We anticipate that we will continue to see regional hotspots and maybe major new waves, as for example, schools reopen, as the weather changes in the fall, etc. We're also uncertain about vaccines. We are hopeful that a number of the vaccines that are in clinical trials now are going to prove to be safe and effective. The truth is, we don't know. We don't know if they're going to meet criteria for efficacy and safety to actually get approved for general use. We don't know how protective they're going to be, how long that protection is going to last, and we don't know how available they're going to be and over what period of time, or even how many people will agree to get immunized. So I think there's clearly a lot of ongoing uncertainty around all of this. And lastly, I think this is just as important in terms of the uncertain environment we're facing, which is consumer uncertainties. We've had a dramatic decline in non-COVID utilization of healthcare, even accounting for the uptick in telehealth delivered care. We know, for example, there have been like 20% less cancers diagnosed in the last 3 months than we would have expected in the same period of time last year. Same thing for heart disease, preventive maintenance stuff, elective utilization for things like knee replacements, et cetera. And we know a lot of that's because the industry has been largely shut down. A lot of it's also because of consumer uncertainty and fear around the safety of getting care delivered in the immediate COVID and near post-COVID world. And we don't know how much of that is going to stick. And obviously the transition to digital and telehealth enabled care, which we expect to continue to increase to a degree, will balance some of that. So we'll talk more about that. But there are a few things that we can be confident of in addition to uncertainty, and that is that many of the same pressures that have been shifting the way we deliver care, the way patients receive care and want to receive care and interact with providers, the definition of who the providers are that they want to interact with, et cetera, have been evolving for some time, and a lot of that evolution has clearly been accelerated by COVID. Additionally, some of the same cost pressures that we've been facing in healthcare have not just continued, but clearly are going to be accelerated. So there's been a significant shift in the Medicaid roles. Currently, Medicaid accounts on average for 30% of state budgets, the highest it's been in decades. And by the end of COVID, that number is just going to continue to increase. No question that cost pressures are going to lead to mandated cost reductions from both the state and federal portions of Medicaid. Medicare is in pretty much the same boat. The solvency of the trust fund is now 5 years, and by the end of COVID, that timeline is going to be even lower without intervention. And additional funding certainly one way to do that, but we expect that cost reductions are going to get ratcheted up. And even though there are not signs of immediate reimbursement fee reductions from Medicare, some of the approaches that Medicare has been taking to reduce costs without fee reductions, reimbursement reductions, are getting accelerated. So efforts to shift provider organizations and patients into risk models rather than fee-for-service models, some specific acceleration of some of those risk programs, including direct contracting, bundle payments, et cetera. And we're not just seeing this with Medicare, but with commercial insurers too. Blue Cross Blue Shield of North Carolina, for example, is actively pushing every one of their members to one of their ACOs, for example. So we think those cost pressures and both commercial and federal payers' reaction to them will continue. Some other big themes are consolidation, certainly across providers, seeing some of that across payers, and a lot of vertical integration going on with that consolidation, especially amongst payers, where now all of the top 7 national payers in the US have essentially full vertically integrated portfolios, including PBMs, direct care providers, et cetera. And lastly, I think we're seeing the rise of disruptors with COVID. And those disruptors include big telehealth companies, including, many of you probably heard about the Teladoc Livongo merger, but also some unexpected potential disruptors, things like Walmart Health, for example, who is not only expanding their provider footprint, but getting into the payer world, initially selling insurance, and we predict that we'll see companies like Walmart get further into the actual insurance space directly. So we go ahead and advance the slide. So the graphic you saw in that previous slide looks like waves for a reason, and many of us, it's easy to feel like we're getting kind of tossed around by those waves and some of the uncertainty. But I think the key is focusing on those things we can't predict. So the economic reality post-COVID, there's going to be prolonged recession in spite of whatever happens in the federal elections, both presidential and state elections in Congress. We know that in addition to the economic impacts, that the effect of the disease is going to be with us for some time. As I mentioned, it's a little bit unpredictable, but I think it's fair to predict that it's going to last for a year anyway. Sorry.
The realities of work from home.
Yes, sorry. That was a Amazon delivery person at my front door, my dog reacting to it. So that's another COVID reaction.
And another disruptor, right?
And another disruptor, right? And then again, I think some of those changes that I talked about from the payer perspective, from the federal perspective, and from consumer perspective are going to be permanent. And it's still a little bit cloudy as to how permanent and to what degree, but you can predict all those things, I think, with a fair amount of confidence. So we can advance the slide, please. So what does this mean in terms of digital health and in telehealth as a component of that, but particularly? We've all seen a massive increase in the use of telehealth, and we'll talk about some data around that here in a minute. And digital health more broadly, obviously a ton of M&A activity, a ton of investment. The valuation of the Livongo Teladoc deal is really surprising and telling, I think, example of that. But what we can take away, what we should take away, and my advice to anybody who's on the care delivery side or in the technology or other support service side of healthcare on the call is that while COVID has been tremendously disruptive and horrifically impactful, certainly to individual people in their families in this country across the globe, there's really probably, if there's any silver lining to this, it's that it's required such rapid change and a degree of nimbleness in healthcare and in other unexpected places like the federal government, for example, that I think not only creates an opportunity, but imperative for all of us to advance the ball much more quickly than we ever thought we were going to be able to just a year ago. So that's my kind of call to arms for all of you is to look at the opportunity side of this and seize it. And I think as COVID shakes out, there's going to be a reordering of the successful components of the healthcare system, and including from the commercial supporters of it, including technology companies. So it's now, as we say on the slide here, it's time to move fast and with purpose, with intent. For the provider side, I think advancing the ball specifically around digital health technology and organizational capabilities around it is critical, not just to survive COVID, but to survive and excel in the post-COVID world. And third is to, as always, put the patient first, because again, the one thing I think we can predict most accurately about who the winners are going to be in that shakeout is the folks who are best at efficiently engaging both patients and providers in a meaningful, satisfactory, and in a way that promotes quality and efficient use of resources are the ones who are going to survive and thrive in that new world. And finally, don't try to do it all yourself. And this is not, you know, a pitch for Optum or Well. There's a lot of companies out there who are some of the traditionals and a lot of disruptors that are getting really good at components of digital and telehealth, and figuring out who those right partners are and making the right bets early, and also not being afraid to partner and not feeling like you have to do everything yourself. Sarah, if we could advance. So one of these keys in the approach that I touched on is not thinking of the emerging digital world as just a way to electronify, if that's a word, the old world in our old workflows, but to be willing to adapt workflows and really be more ambitious, I think, in what our goals are, and at least in a much faster timeline than any of us were thinking a year ago. And one of those areas to be more ambitious is about reach and access. And without having patients rolling in the doors of our facilities on the provider side, both inpatient and ambulatory, we've all had to rethink how we not just provide care to the populations we serve, but how do we communicate with them in the first place? How do we let them know what they're eligible and due for, what they're overdue for, what they're at risk of? How do we best engage them in a positive way? And how do we take advantage of what we've learned from healthcare, but also probably more apt, what we've learned from non-healthcare industries to get really good at that positive engagement and communication using technology. Secondly, in the purple box here, beyond the patient experience, also think about the provider experience. So the definition of the quadruple aim is variable depending on who you talk to, but extending the triple aim to include provider experience in a world where provider burnout has been higher than it's ever been in healthcare, and we haven't really assessed it very well in the COVID and post-COVID world yet, but with a huge number of independent providers and small groups now under massive financial stress, I think provider burnout is going to become a critical limiting factor to our ability to emerge safely and effectively from the post-COVID world, and figuring out how to engage providers effectively and improve their experience in the care environment going forward is going to be key. In that third box there, this really probably should be at the top, which is how do we improve care using some of these new digital and telehealth tools? And I think that's the bar we should hold ourselves to, not just, you know, how do we provide care remotely as well, but how do we do better? And I think one of the hard realities is we don't know yet what the impact of this massive emergence of telehealth is going to be, both on neither on cost or quality. I think there's small studies out there pre-COVID, there's studies going on during COVID that can provide some hints, but until we have a chance to observe telehealth working at scale, there's a lot of questions left unanswered. And I think assuming that we're going to do as well or better with these digital tools without being self-reflective, intentional, and academic about it is a mistake. So we all have not just an opportunity, but imperative, I think, to really be focused on how do we improve care using these new tools as we go forward. And in addition to the clinical improvements in the green box here, obviously also we have an imperative to be able to improve efficiency, do that while we do that, reduce inappropriate utilization, improve adherence to evidence-based best practice, and reduce total cost of care along the way, because our current trajectory is obviously unsustainable. And lastly, I think this innovation point is one that often gets lost in the day-to-day struggles of surviving COVID and all of its political, financial, social, and clinical impacts is the opportunity to embrace innovation in a way that has been really approached much more with kind of fits and starts in the healthcare environment. And all of us, I think, now can see a world where we can be much more efficient and successful and quick with innovation than we ever were before, as long as we continue to embrace the willingness to innovate, to drive change, and to experiment in everything from care models to specific care delivery to payment models, etc. Sarah, if we could advance. I know we're a little bit behind time here, Guy, so I'm going to try to go through the rest quickly and then turn the ball over to you in a second here. But I think the other important thing to remember here is that digital health is not something that you should, toss to a IT team who's in the basement of a hospital or an admin building somewhere. That this is really a team sport, and if we're going to achieve all those things that I just talked about, you've got to have your finance team all the way up to the CFO fully engaged in this, and some folks might say leading it. You're in the bottom right corner. Obviously, your clinical leadership in clinical care has to be at the helm of designing and promoting the implementation and utilization of these tools. You do have to figure out the tech side of things, and especially how to integrate some of these emerging solutions with some of your existing platforms, which is really challenging, as many of you have experienced, I'm sure, but necessary now. And there's really not out of the box magic, kind of integrated answer out there. In spite of what you might hear from some integration companies, it's still challenging work. And then from the operational side, it's easy to forget. I think ops and tech often in these times of innovation seem kind of like the parts of this whole care delivery process that we just assume are there and gonna do okay. And operations is going to get massively disrupted by this emergence of digital. And that I think applies to really every component of the care delivery system, but it also applies to how those different components of the care delivery system interact with each other, especially as this idea of digital health being a team sport is extended not just to a team sport within the walls of a provider group or a hospital or a health system. It's really a team sport between provider organizations, payers, tech companies, et cetera. So that same concept, I think, is going to get expanded exponentially as more and more parts of the healthcare environment start working together digitally around, through, and with our shared patients. Sarah, we can go ahead and advance.
Great. And I know, John, you're about to walk us through a case study on Optum Health, but John and I were talking, I think it was earlier this week, about Livongo and Teladoc and some of his findings. And we've been able to see a lot of this in our own data as well. And speaking to telehealth specifically, there are so many different things and competing ideas on how to adapt as a physician organization or a health system today. Telehealth obviously is one of those that's at the forefront. One thing that I'll be interested in hearing about from you, John, is just what are the stopgaps that need to be made, today and that solve problems that will go away in a year, and what are the long-term changes that will persist? And telehealth is an example of one of those that we just see continuing. Depending on where you are regionally, you may be seeing that second wave spike globally, and I'm sure many of you have seen a graph that looks exactly like this. Our data shows the same information, but globally, we're seeing telehealth kind of persisting at a 15% of total visits range when it comes to recovery. One thing to keep in mind, and one thing that I don't think has received enough attention, is that 43% is a huge number, 43% of total visits, but we have to remember that at the peak, that April 6th peak, our visit volume globally in healthcare was at 50% of pre-pandemic levels. So telehealth only really ever got to 25% of total visits pre-pandemic levels, which is still a huge leap from 1%. And as we look at that recovery around, 10-15% of total visits, that's still only off of about 85% recovery. So this is one of those areas that seems like it is here to stay. There are new waves happening, and we're seeing those in our data. And I'll be really interested as we get into the Q&A, John, to hear from you on, what are those investments that need to just be made quickly, and what are the ones that are going to be long-term and persist and really require potentially a deeper partnership between healthcare IT organizations, consulting organizations and strategists, and the health system itself. So with that said, I'll hand it back to you to talk about some of the work you did with Optum Health.
So as many of you are aware, I think, at Optum, we have a care delivery arm, which encompasses both primary care providers. I'm sorry, Sarah, if you could advance. Primary care providers, specialty practices, and urgent care. We've been sort of a quietly emerging giant. We are now, I think, the largest provider organization in the U.S., short of DoD and VA, with about now, this is actually closer to 55,000, I think, providers, either directly employed or contracted. And obviously, we like the rest of the care delivery function in the U.S. were, I would say, not behind the curve, but we were right there on the curve of telehealth utilization and telehealth capability. So it's not just a matter of, were patients willing to get on the phone or in a video visit with a provider. It's just how many of our providers actually had access to video visit capability, how many were trained in how to do it, and never mind how many were actually good at doing it. So we had to go from a couple percent, I think, utilization of telehealth visits to rapidly scale up. And within the first 3 months, we onboarded, trained, and had over 200,000 visits delivered through over 10,000 providers across the United States. And this was not just that number, by the way, now is up to about 30,000. So it's been a massive effort, but it has not been just a, hey, we have a telehealth vendor, go use it, or we have telehealth vendors, go use them. It really required a very intentional effort, oftentimes over 100 people. Now we're a massive organization, but over 100 people working simultaneously on developing and implementing, orchestrating the kind of war plan around this, and then being out in the field, virtually at least, engaging, training, and supporting our providers and the support staff to be able to deliver care in this way. And I think we've learned a lot of things about ourselves along the way. Some things that we are really good at, and one of those is the ability to scale up and do things really quickly when we put our mind to it. And other things that I think we have to do better. So we've often run into challenges stretching the technical capabilities of even just our networks and hardware. And like I think most organizations, I would say we've had largely good, but still variable uptake and effectiveness of individual providers in getting engaged in this virtual world. I think the other interesting lesson for us has been as a matter of just pure requirements. So in a desperate times call for desperate measures kind of way, desperate's probably not the word my bosses would like to hear me use, but critical times called for critical measures and focus, we really focused on ensuring our patients had access to primary care visits for COVID and non-COVID through rapid expansion of telehealth. What we initially were not as good at is ensuring that we engaged our patients with other digital capabilities, home monitoring, chatbots, et cetera, all of which are part of our portfolio. But we really didn't do a good job of integrating those things right out of the box. We pretty quickly recognized that, and once we had some early success and we're making progress on the telehealth side, started to engage those broader capabilities. But that's a good lesson for all of you who are not there yet. I think I'm thinking holistically about digital capabilities, not just telehealth. And secondly, I think the other really self-reflective lesson we learned is, again, we were focused on just keep providing basic care and access to that care, and we didn't do as good a job at thinking about preventive services, chronic disease management, risk score capture, quality score capture, all of those issues that are critical to both clinical and financial performance of complex provider organizations. So again, we've pivoted pretty quickly. We've integrated a lot of our clinical decision support tools, including risk adjustment support and quality and care gap support, documentation, analytics, and chronic disease management, et cetera, into our telehealth platform. So we've pivoted that, but there definitely was a lag. And again, I think one of those things to watch out for all of you. Sorry, you can go ahead and advance. So Guy, I think I'll stop there, and you may have some closing comments. But before I toss the ball back to you, I'll just say, if we've gone through a lot in terms of kind of what's happening, what we foresee happening, what's still really murky, and much of it, I think, I would hope that many of you were shaking their heads in agreement, seeing and experiencing the same things, and maybe saying, like, no duh, to some of these. But I think the final words I'll leave you with, and we'll answer some questions, are urge all of you to take the opportunity, not just to survive, but look ahead to be able to thrive in the post-COVID world. Understand where there are potentially new competitors emerging that you can better compete against some of these disruptors if you're proactive, if you're innovative, and if you're intentional about preparing to thrive. And I think if for those who don't, many of these disruptors, including some of these national telehealth and digital companies that don't have geographic borders, and they're the ones who are going to be the competitors. They're not in your primary and secondary service areas. They're in everyone's primary and secondary service areas. So, my urge to you is from a business perspective, don't be one of the organizations that gets left in the dust as the dust settles. And most importantly, from a clinical perspective, take this advantage to improve your capability to deliver the best quality and better quality than you could pre-COVID, and best efficiency to your patients, and fulfill that compact with them that we all have.
Thank you, John. And Sarah, feel free to go to the next slide where there's our contact info while we jump into Q&A. And just a reminder, feel free to post questions on the right-hand side. I've got an encyclopedia full in my head. So I'm going to probably start with one, John, that I imagine is on everybody's mind, which is cost. You opened by kind of talking about a lot of the cost pressures, Medicaid being a big portion of state budget. I know that CMS is slow to report enrollments in services like Medicaid, although the Kaufman Family Foundation looks at enrollment, MCO enrollment, and I know they published some of those findings in May. particularly Nevada, already a 14% increase in Medicaid MCO enrollment. Missouri is not far behind. Wisconsin, just over 8%. And you mentioned that just implies that there's going to be mandated cost reductions. The federal government won't be able to cover that gap forever. So, there's quite a few safety net providers on the call today who probably get most, if not all, of their revenue from, Medicaid and potentially Medicare. If you were one of those providers, what should they be thinking right now with the uncertainty around reimbursement, already, running a business with probably pretty thin margins? And you may be muted, John.
Sorry,
there we go.
Yeah, great question. Great question, Guy. And I think one of the most pressing issues that we are all going to have to face as we come forward, those, a couple things. Risk adjustment's not going to go away, and it hasn't gone away. At the same time, nobody's getting touches on the ball for closing care gaps and getting credit for risk adjustment. So RAF scores, which were already pretty much separated into a few exceptionally effective, comprehensive ability to identify the entirety of the risk of individual patients and populations, and a whole bunch of folks who are trying to catch up to those folks who are really good. That dichotomy is just going to get worse. And thinking about in the immediate term, how do you take advantage of this shift to digital and telehealth to get really good at doing that and managing your populations, identifying care and coding gaps and closing them, enabled by digital technology, and being able to communicate with them, prioritize your population, prioritize the conditions that you need to manage with and for your patients, and how do you engage your patients using effective communication strategies, and how do you orchestrate all of this through kind of a more unified communication approach with your patients is key. Secondly, this shift to value-based reimbursement will just accelerate in various models, and having technology as a core foundation in a number of fronts to be able to support the now inevitable acceleration of the shift to fee for value that all of you are facing in the immediate future will be really important. Again, I think right now it's an opportunity, as many folks are struggling, treading water to kind of survive COVID. Embrace it, get really good at using your existing technologies, and find the right partners to be able to help you be successful in that future world. And then lastly, we've cut a ton of waste out of healthcare, no question. From in the past 20 years, our expenditures are still going up. We're still we're still the most expensive healthcare delivery entity on the planet. But in spite of that, we've cut out a ton of cost. There's still a lot of cost and waste in the system that's been shown over and over. And we are all going to have to utilize technology to get much better at preventing inappropriate utilization and choosing the most efficient, effective treatments, diagnostics, consultants, referrals, inpatient partners, et cetera, to be able to fit into this new cost restricted world.
Yeah, that's a good point. Naturally, everything you're describing costs money, and we're many folks, probably everybody on the call, is looking at either mandated cost reductions or loss of services that we're bringing in revenue. Not as many organizations are fully value-based. A lot of folks are still on that journey. So one of the things that that I'm interested in, you talked about care gaps, telehealth, communications, risk scoring. those are incredibly expensive. The existential threats, Walmart, Amazon, et cetera, they have money. So how do you rationalize that? How do you make the case for investment? Where do you find the money? What's the right strategy? And if I can add to the question, as you layer in, investments that need to be made today, that need to be made quickly just to keep things afloat, and then investments that maybe need more thought, that need to be done in the long term, what's the right way to do that? I see folks taking off the shelf technology from the EMRs that might not necessarily be best in class. There are folks who are choosing not to do anything and maybe, doing furloughs and shutting down doors to find money. Have you found a strategy that's particularly effective at rationalizing the right investments, but also cutting costs in the right areas? What have you seen? Who's done the best job at this? What have you seen work well?
Okay, there's a lot there, but I do think there's a spectrum of answers to that question depending on where folks are starting from. So the parts of the provider world that have been more heavily and early pre-COVID pivoted to value-based reimbursement models are doing much better right now, right? And some of that might come back to haunt them as in the post-COVID world, a lot of the deferred care results in worsening of underlying chronic disease, undiagnosed subacute conditions, et cetera. But for now, anyways, a lot of those folks are in a better place, are less restricted financially to be able to make some of these investments. I think for those of you who are really, struggling, have been largely fee for service and just kind of doing the best you can, tapping reserves and hoping that some of the resiliency you've developed and hopefully financial resiliency tools you've got at your disposal, as you see that dwindling, I think folks are going to have to start to make bets. So some of this will result in consolidation, and it's happening at every level, from individual providers either retiring or selling their small practices, merging with larger groups, or getting acquired by mega groups or large IDNs. And I think a lot of that is real. I think one of the options that we're seeing folks take advantage of is partnerships. So folks taking advantage of third-party companies that are willing to absorb some of the capital costs of launching these capabilities up front with, and sort of betting on the come that they're going to pay off in sharing the long-term results on quality and efficiency. But I think what's clear, if you look at some of these national organizations that have been lurking and quietly growing, or groups like Adelaide and ChenMed, Oscar, Walmart. These folks are doubling and tripling down on their investments right now, getting ready for this post-COVID world. And I think folks are going to have to be creative to develop these capabilities that are going to be required, or they're going to have to partner, or they're going to have to think about M&A activity to survive. And I not to sound like doomsday, but I think all those threats are real. So figuring out who the right partners are, being creative about how you partner with them from a business perspective. And if independence is the goal, then it definitely will require, I think, some creative business models with your partners to be successful here.
Yeah, and the exits, the M&A, the consolidation that's happening right now, it's I would assume it's outside of some of the telehealth plays, take Teladoc and Livongo. In the provider space, it's going to be a lot of bargain hunting, right? It's going to be folks that are hurting and buying at the bottom of the market. One question I have for you, John, as you think about value-based care, it's the future, and I don't know if you have predictions on what that'll look like at the end of the decade, but when it comes to vendor contracting and making investments, have you seen much within your network, much of a change in terms of risk-based vendor contracting instead of kind of traditional, you're going to pay me this much for your services for this amount of time? Have you seen a shift at all in your interactions with vendors and providers?
Yeah, another good question. So, for years now, we've been selling our services, be it technologies, care delivery services, home health, whatever it is, and being willing to provide those services in an at-risk kind of way. Typically, what we see is everybody wants to talk about risk with their vendors, but once they get convinced that the vendors are going to deliver, that usually shifts quickly because they realize the vendors aren't going to want to deliver services or technologies in an at-risk way without more of an upside. So people sort of quickly say, actually, we'd rather pay less, and now that we're confident we're going to get what you're promising. What's interesting now is I think the financial challenges in COVID and post-COVID are really forcing all of us to be much more diligent, and we're seeing a lot more deals now, not just from within Optum and our clients, but across the industry that are risk-based. I think the other thing we're seeing is there are ways to accelerate outside of risk reimbursement models. There are ways to accelerate revenue realization through some of this work that can help pay for some of the tech investment. So, for example, with risk adjustment, you can use tech to review your documentation from delivered visits and resubmit with some time limits beyond the scope of this conversation to talk to about the details and the compliance issues and so forth. But for most organizations, you can do that and actually find a whole lot of risk dollars that you are due and just didn't get credit for. So you can get real, creative that way and try to figure out ways to fund some of these investments through accelerating and identifying revenues that were out there that you just didn't know you had access to.
Yeah, and it's, I haven't, reflecting on, COVID for our business, we've done a lot of business, during this period, and I have been surprised. I have really not seen many requests for risk-based contracts. And John, I think part of it is once people are sold on the value, they realize that they don't want to go at risk. Because it'll be net more expensive. But I do think one strategy that may be worth considering for folks on the line is that, if the budget's not there to pay for the solution today, a true at-risk contract with a vendor could allow you to move very, very quickly. And if you sign a short-term contract and you get a fixed price at the offset, you could work into that contract potentially. And John, I might not be doing either of us favors, but you could potentially work into that contract, the option to switch to a fixed price at year 2. So I think there are creative ways to be nimble and flexible and make some of these investments while managing the cost structure. I don't know if that strategy would work at Optum, John, but I haven't seen it. I've been really surprised that I haven't seen this come up at all in the last few months. So I think I'll close. Go ahead, John.
Sorry, yeah, I was going to say definitely. We definitely have seen that, and I think everything from those risk models to deferred invoicing. We're definitely being creative, trying to help our partners through this. We are more able to do that than most because of size and financial position, but I think for all of you, as you think about your technology vendors that you have and those that you might want to engage with, you should expect folks to be creative with you to enable you to make the investments now that you need to be successful in the future.
And if they give you a hard time, just let them know that John at Optum does it, so they should they should follow suit. Just kidding. Hopefully we'll have to mute that from the audio recording. I'll close. I think we have time for one more question. So John, I'm gonna close with maybe a hairy one for you. I'm gonna put you on the spot with this. If you were to predict, value-based care, what that'll look like at the end of this decade, what percent of overall healthcare dollars do you think will be on value-based plans?
So I would actually say in the next 5 years, that 75% of care is going to be through value-based reimbursement mechanisms. There's always going to be a role for fee-for-service, and even if you look at the kind of global experience, the folks are always going to want to be able to have that, but there's no question that healthcare is getting more expensive. Advanced therapies, you look at CAR T therapy, other kind of personalized cell and gene therapy. Diagnostics are getting more sophisticated, more expensive technology. All of this is going to continue to threaten solvency of governments, and I don't say it that way. I think that's real, and we're going to see more and more and more, not just push but requirement for value-based reimbursement, both from I think globally we're seeing it largely, and in the U.S. it's clearly on the immediate horizon, both with federal and commercial payers.
5 years, 75%. I certainly wasn't expecting that answer, but I'm glad we have you on the record. John, I have always really enjoyed our time together.
Yeah. Put a tickler on our calendars, and put a tickler on our calendars for 5 years from now, and we'll see.
Well, thank you so much for your time and for sharing all of this wisdom with everybody. As I mentioned, just have always enjoyed our time together. And I want to thank everybody for joining. And this will be made available via recording soon. Our contact information is on the page if you have any follow-up questions for either John or myself. Thank you again, John.
Take care all.